Thank you so much to both moderators for inviting me to speak. I'm going to speak today about the management of generalized peritonitis and perforation, and I have no disclosures. So if this happens inside your patient's peritoneal cavity, I think everybody in the room should know what to do. It's really actually quite easy. Ubi pus ibi evacua. So I asked Google Translate what that means, and it got it wrong. It said, where there is pus, empty pus. Really, the translation is, where there is pus, empty it, right? So we clean it out. The question is, what do you do after that, right? And so for 80 to 100 years, the answer has been, give people a colostomy. But as all of you in the room know, that's associated with a significant risk of morbidity and sometimes mortality. The modern rates are lower than what's quoted in this paper, but super high risk of wound infections, and these patients are in the hospital for weeks. What's worse is that a large proportion of these patients, maybe not in major metropolitan areas, but certainly in other places in the country, never get reversed. So many people have looked at different ways of managing these situations without using the tried and true Hartman procedure. So one of the first observations or techniques that were attempted was the laparoscopic lavage. What you're seeing here is a little bit different, but sort of the same concept. The patient is accessed laparoscopically, and the peritoneal cavity is irrigated with several liters of fluid. Here we're unroofing the abscess. This is different from the randomized trials that I'm going to describe, where they didn't do any of this. They just washed out, put in drains, which you'll see here in a second, and then they observed how the patient did. So we have 3 randomized trials. The first is the ladies' trial, which was lap lavage versus sigmoid resection. That trial was closed early because they had a higher short-term serious event rate in the lap lavage group. And that was mainly due to recurrence of abscesses that had to be percutaneously drained and occasionally operated on. Scandiv was a similar setup, except their primary outcome was complications at 90 days. The reoperation rate, again, in the lap lavage group was higher, 20 versus 6%. But at the end of the trial, no differences in quality of life. And then Dalala, which we'll come back to because it had 2 arms later in the talk, was lap lavage versus colostomy or Hartman. I don't know any patient that would sign up for this study, but anyway, they were able to pull it off. And the outcome here was reoperation at 1 year. That was similar in both groups. There is a lower rate of intervention in the laparoscopic group over 12 months. So Dr. Francis here, in his recommendations from SAGES, said that lap lavage can be considered in selective Hinchy 3, and I think the contribution of our last speaker is really important, that maybe we shouldn't be using the Hinchy criteria. Let's say CT Hinchy 3 criteria, with surgeons with appropriate expertise and the ability to watch for these recurrent abscesses and other problems that these patients sometimes develop. You can consider doing it. We said don't do it in patients who have feculent peritonitis, obviously, but you could consider it in purulent peritonitis, although the ASCRS prefers that you take the colon out. So what if you are indeed going to take the colon out? Well, what do you do next? Well, it kind of depends on the condition of the patient. If the patient's critically ill, then your options are somewhat limited, and you might be pushed towards just making a Hartman or doing something quick and easy. One thing that I see a lot in my institution is, and increasingly so, is a lot of folks with perforated diverticulitis being left with their abdomens open. And this was new to me because usually we just wash out, close, and make a stoma or an anastomosis and go home. As you may know, delayed closure of the abdomen is a technique that's been well developed in trauma populations. but this has recently been extended to the care of patients with diverticular disease. And so a lot of the data that we have on this is really observational. There are no trials comparing damage control to standard technique, but I thought I'd share some of what's now being reported about it. So one of the things to really consider, and this again goes back to what our previous speaker said, is that a huge proportion of the patients that were getting this technique are not even septic, right? So we are misclassifying people based on the CT scan, so we really have to understand this patient group better. And what's more, this jives with this first observation, is that 60-something% of those patients underwent anastomosis, indicating that the findings really probably weren't that bad in the first place. So I think this technique of leaving the abdomen open can be over-applied, and maybe it's probably not necessary. The other thing is you wonder about some of the technique of the folks doing this, because when they did do an anastomosis, the leak rates were 7.5, which is a little bit higher than what we would traditionally expect in an elective setting. And again, this is a sick group of patients, so mortality around 10%. So again, Dr. Francis's paper suggests that Hartman procedure is the preferred operation after you've resected the colon in a bad situation, but that you can consider, use of damage control laparotomy if it seems appropriate. So what about just making an anastomosis, right? A lot of times you get in there, patients not doing poorly, they're doing okay, the anesthesiologist is happy, you're not feeling too tired, and the bowel looks good. So an anastomosis might be inappropriate in that situation. So there are 4 randomized trials that we have to guide us on this. This is one of the first published study in Switzerland comparing anastomosis and loop ileostomy versus Hartman procedure. The primary outcome was complications during all procedures, so during the index operation and also in the reversal. And you'll see this pattern over and over again. I only have 8 minutes today, so we can't go through them all, but this is the key. The stoma reversals were way higher in the anastomosis and ileostomy group, 90 versus 57%. So a lot more of those patients got reversed, and the complication rate was much lower in the anastomosis group when compared to the Hartman. And so we have 4 other major RCTs, and you just have to trust me on this. You can read them. They all show the same pattern. This data has been meta-analyzed, and we've done if I can make a verb out of that, and systematic reviews have been done, and again, it shows the same pattern. Rate of non-reversal is lower in the anastomosis and ileostomy group. Morbidity is lower in the primary anastomosis plus or minus ileostomy group. It's raining on me, so I guess it's telling me to get off the stage. And again, when we look at overall mortality, morbidity, surgical site infection, organ space infection, anastomotic leak, it all favors anastomosis and loop ileostomy. So, in conclusion, patients with diverticular disease are highly variable. Laparoscopic lavage is feasible, but you have to watch the patient really, really closely because a lot of them are going to get other problems and you have to be all over it. Damage control laparotomy is feasible, but you have to have a plan for what you're going to do after that. That's not a solution in itself. And then anastomosis and ileostomy appears to have a role in the management of feculent and purulent peritonitis. And it actually appears to be favorable when compared to Hartman procedure. Thank you very much.